Welcome back to the final day of Build 3.0. Let's start our much awaited sessions, Legends Meet. I invite the experts for our first stop, Professor Dept and Professor K. Rajendra Reddy on the stage. I also invite the chairpersons, Dr. Firsosh Mistry, Dr. Raghuram Kondala, and Dr. Awwal Zadikot. I request the chairpersons to introduce the speakers.
Now I request Dr. Shukla who onto the dais. He is going to talk about 5 papers published in the field of medicine in the last decade that will change how we live in the future. Dr. Shukla doesn't need any introduction. He is one of the doyens of gastroenterology and hepatology, and one of the reasons why most of us choose this path. So over to you, sir.
Thank you so much. I find more people standing out. It means there is much more to be known outside than inside. But that's alright, the way it is. Next, please. Instead of 5, I tried to struggle to concise in 10 and I will be brief. And because I have two of the best giants to whom I send their slides in the morning. So, medicine is a science of uncertainty and an art of probability. So whatever I am saying, you please take it with a pinch of salt. My aim is each of the guys who is here makes better sense and more discoveries than what I collected. I'll briefly run through the list of Nobel laureates just to tell you in 2024 it was the microRNA, 23 the vaccines, 22 the genomes of extinct hominids and human evolution, I could read that. 21 receptors for temperature and touch. Imagine we thought we all know it. The discovery of hepatitis C, all our dear friends. 19 was discovery of how cells sense and adapt for oxygen availability. 18 cancer therapy, which we all are now using. 17 circadian rhythm. 16 autophagy, and 15 for helminths, discovery concerning novel therapy against malaria, and 14 for discoveries of cells that constitute a positioning system in the brain. With these great giants, and I couldn't read them, but just to tell you that Nobel Prize means something very noble, and what I am trying to show you might also take things to the next level in this planet. But let's start at home, our own clinic. Now here is a whole body magnetic resonance imaging, MRI at 0.05 Tesla. This science paper shook me. You just plug in the MRI in your clinic. This is a home ultra low field MRI. Cheap, common and magnet on a standard wall outlet, no need of height. And radio frequency, and what it discovers is like this. So you have this MRI machine. It will be using a machine learning in which all these images are there. So you sitting in the brain, spine, heart, neck, and knee. So these signals are now using deep learning will take you to develop images. without using MRI, and you will get images of brain, abdomen, spine, everything. So this is where your deep learning can take you. You have a 0.05 very low cost MRI. Don't you think we all want this? Alright, should be there. This is a breakthrough discovery of AlphaFold and its revolutionary impact on medicine. Now what every time we used to do is a protein and a drug, a protein and an antigen. What this did again by using a neural network based model called AlphaFold, and this is the 14th edition, 14th revision of that. They were able to find using Cas14 protein structure. How? They were using the deep learning methods, neural networks. They were able to find out the structure and cover 200 million proteins. They are free, available on the net, and these protein structures, 3D structures, functionality, now you can design new proteins, you can design drugs, you can model how proteins interact with drugs and viruses, you can understand protein malfunctions and cancers, you can get new enzymes. To me, this is the beginning of new discoveries of disease pathogenesis. And I talked to my friends around, they said probably this will get a Nobel, AlphaFold and its revolutionary impacts. Do read this paper. The third thing which fascinates me, and we are using some of it, is micro robots. What is a micro robot? It's a tiny 5 micron to maybe 5 millimeter. They can navigate in your blood vessels. They can navigate into the tumor. They have limited power and they can be guided by optical like a light, by acoustics, by electrical fields or by magnets. And they can be made up of biocompatible polymers, metals. So now you have a drug delivery or an agent delivery or a method of diagnosing a tissue. Let's see how it can be used. For our purposes, you want to get into the bile duct and continuously deliver the drugs. So what you will do, you have a modularized micro robot. You can put it through the bile duct. This will go into the bile duct and keep releasing into directly your cholangiocytes or in your bile. And these micro robots you want at the bottom, you want to go up and you can modulate it and have radios or the drugs delivered inside. Let's go further. This is again a beautiful science paper, biohybrid micro robots. Now you have a person who has a lung metastasis. Now you will prepare a robot which goes into the metastatic tumor. It will bind to maybe RBC membrane or something, and slowly over a period of time, your whole lung, not the healthy lung, only the metastatic lung, you will be able to guide and deliver the micro robot based deliveries. Don't you think it is exciting? Now comes the new generation of gene editing. We have been talking about it for almost 3 decades, but now there is a clarity that genome-edited cell therapies can be used. How do they work? Normally, in a patient who has got hemoglobin is made up of 2 of these chains. One of these chains, if it is not working well, then you get a oxygen-based sickling off. If there is a low oxygen, the RBCs can get sickled out. So there is a gene, BCL11A. This is the gene which causes hemoglobin F, the fetal hemoglobin, to come down. Now let's say you knock out this gene, then you will have hemoglobin F coming in. hemoglobin F is as good as the second gene which is needed for making hemoglobin. So what these guys did, they knocked out the BCL11A. Once the BCL11A levels went down, you have both gamma, which is a fetal hemoglobin, and the second gene, and you were able to make a proper hemoglobin. This therapy was not available earlier, but now fetal hemoglobin replaces the gene which is defective in the sickle cell disease using CRISPR-Cas9 technique. This is one of the usages of CRISPR-Cas. There are many more. Let's go to the Indian market. India is proud of Alok, who is there in CMC below. Alok had been working for almost 15 years on hemophilia A. What Alok did was to use an antiviral gene therapy by using adenovirus, lentivirus. He was able to give you a transgene factor 8 gene. Now, if you are able to give factor 8 gene, you will be having no bleeding. The hemophilia is treated. This was always a dream, but now using an antivirus, he was able to see in 5 patients for a period of 81 months, there was no bleeding. So here is the discovery. Now this gene therapy, the editing part is very much in vogue, and I think in the next 10 years, we already have it for dyslipidemia, for hypercholesterolemia. We are having this for hemophilia and sickle cell disease. All of you are fully aware, and I know both my experts are very much wanting to take questions, but I'll just first probably run through the presentation. So 3D bioprinting, and now it is 4D also. You can just make houses, make organs. Let's see what organs can you make. You will have cells, molecules, polymers. You have the ink. The ink will write what kind of material it has. So the ink will have all these 3. You can make trachea, heart valves, blood vessels, skin, bone. Liver is not there, it is too complicated. But people are trying to have a 3D liver. I think the future will have a lot of 3D printed biomaterials. Look for it. Dr. Raj Reddy was telling me in the morning how he is working on million veterans who start working on the polygenic risk score. Also on the donor, for a surgeon, the donor and the recipient. So this is the age of digital twin. Whatever is your whole exome, you have 20,000 genes, and you make a digital twin, and this digital twin will behave as if you are there. Now you take this digital twin to the recipient. You take this digital twin to the drugs, and the digital twin will give you how you will react when this drug is given, how you will react when you get this liver into you. And this is the area most of us should be working, and I definitely want digital twins to become a reality in India. I have my digital twin where I can use any drug. What reaction will I have? Now, the next area which I feel will change is the use of porcine organs. Now, how can we use porcine organs? Came in this New England paper where they used cardiac xenotransplant 3 years ago. The patient was weaned from ECMO, a xenograft was placed, and it worked for almost 49 days without rejection. He died of something else. How did they achieve it? Please see carefully. The pig was clonally derived from fibroblast, a cell line that included 10 gene edits. Let me go to the next slide first. So here is a pig. You have the embryo, you genetically engineer by nuclear transfer and cloning. And after this you have the next stage, blastocysts and others. Then you get a grown-up pig. So this pig is also at the very early stage genetically changed. Now this pig has organs, has tissues, has cells. All these can be used into human body. Now how have you done the transfer? So there are 10 genes which you need to change. 3 of them are your immunodominant carbohydrate knockouts. Then you would like the intrinsic xenograph to grow, but your human growth hormone has to do that, not the pig growth hormone. Then you have to mitigate the antibody dependent complement graft injuries. Then you have to see that your thrombomodeling endothelial receptors, and finally the anti-inflammatory CD47. I come to it again. So that was the heart. Now we come to the real scene for a kidney. Again the same philosophy. In the very birth, this is a clonally grown pig. What are the pig genes removed here? So pig genes, carbohydrate genes are removed, and endogenous retroviruses, this was additional, was inactivated. Now human genes are added, the complement inhibitors, anticoagulants, and immune regulators. These 10 genes were changed in this, and then this animal's kidney was taken in. This came in nature. Transplant was done. The animal, the individual died. But the fact of the matter is, we are there to have an animal grow human organs. It may take a year, it may take 2 years, and I'm told Dr. Reddy is close to doing more experiments in these. I think the future will lie. We have been trying to get organs, but let's see if this works. COVID showed us mRNA vaccines can work. Can they help in our fight in preventing cancer? Let's say what happens normally. You have a tumor. The tumor gives the antigen, the debris. These antigens are picked up by antigen presenting cells. These are DCs or some. They will invite T cells, and the T cells go back and kill the tumor cells. Now suppose the tumor microRNA, mRNAs, not micro, mRNAs, messenger RNAs are taken from here. I have now a messenger RNA, I give directly the RNA. This is the way the vaccine was developed. So my messenger RNA goes into the DC. Now the DC knows there is a tumor. There is no tumor, it is a cirrhosis. You have given me mRNA vaccine. Now your T cells are already ready and you will not develop a cancer. Is this clear for you? So the messenger RNA, mRNA based vaccine for cancers are ambiguous. How can you deliver this? This is the challenge. Let me show you. So now what they are going to do is use a mRNA which is multiple mRNA. This can be the gene, this can be the mRNA, this is the way. You put all of them into nanoparticles. This nanoparticle now you have injected. This will go into the lymph nodes and the process I told you. So now the next level is delivering the cancer related mRNAs into your body and make your immune system ready to prevent cancers. And I hope, I really feel this is possible. Let's go on to the gut microbiome and its Oration. This is a beautiful paper. This paper tells you that you can sample the bowel microbiome at different levels using two simple formulas. One is the pH, second is the time. So these guys take swallow 4 capsules, 1, 2, 3, 4. The capsule will open up, suck the solution or intestinal or gastric juice at a given time and at a given pH. It will take a sample from stomach, it will take a sample from there. So now you have device 1, 2, 3 and 4 and you are able to find out what are the different types of bacteria in different locations, and there are 15 participants, and they tested the device, and they tested the stool, and they were able to find with ease and reproducibility different locations, different microbiome. I think this should become a reality. You don't have to do stool tests. Gut microbiome will decide our next decade, and I hope I'll show you some data. Just to give you simple thoughts, these are high five. We started the first ever trial in liver using FMT. This was the group which was given FMT, 8 patients, and this was who survived with FMT compared to healthy control. This was beginner's luck. It was good. What I want to show you, at 12 months following the FMT, you still have a reduction in several of the bacteria and benefits in several. So they stay for 12 months. You can have more run chains, you have more C5 and others. This is the beginning for liver diseases and using FMT. Now I go to something which is beyond FMT, which we are trying now, is edible exosomes. That Docker's carota is a black carrot. Black carrot is something amazing. Normally what happens in patients with encephalopathy, you have more of ammonia and you have a urea cycle. I am not going to detail which is distal. Now you give black carrot exosome, which is a small 150 to 100 micron. This changes your arginine cycle, albumin improves, bacteriocracy, clostridium, these are all changed, and you restore the gut. This paper is under review. I am just showing you the beauty of how. Now, what is the advantage of exosome? 1 spoon of exosome is equal to 2 kilograms of black carrot. The patient cannot have 2 kilograms, he is grade 1 or 2 encephalopathy. Now, where do these exosomes go? So, once the animal is given, you will see in 2 hours, in 6 hours, where are your labeled exosomes going? This is the black carrot. These are the exosomes. I just want to show you the beauty of exosome. Now, exosomes can give you FMT. The fecal microbiota contents can become the cargo, the carrier is the exosome. Let me go to the last one, probably last slide. We are all very happy with GLP agonists. GLP agonist was approved in 2005 by FDA, exenatide, for treatment of diabetes mellitus. But nobody, very few would know that this is normally present into the Gila monster, in the saliva of the Gila monster. This is the Gila monster. We have lost this. Either you take the saliva of Gila monster or you take a GLP-1. I think we all like to do that. Now the mimics are all coming, new drugs are all coming. What I want to show you is that basic common sense was missing, and GLP agonists came in the way. With this, I would like to now stop here. The future will belong to liver. Start next generation sequencing. What is next generation? All of you, whether you are above my age, next generation sequencing starts now. It's a high throughput. Everyone has to give a high throughput to have a future which is ready. And I want to thank all my molecular and cell medicine colleagues who made me present this work. Thank you for your kind attention.
Since there was an outstanding overview of some key areas, if I may, I'd like to comment on 2 papers because someone involved. First is the gene therapy work, and there's been quite a bit of work that's been done in gene therapy for a variety of conditions, hemophilia, spinal issues, etc. And this is important for hepatologists because there's an aspect of gene therapy that we are likely to get involved as time goes by, and that is hepatic manifestations. There are certain abnormalities in hepatic biochemical tests that happen after gene therapy. And it's a sad story. When I first went to Japan, there was actually a Dept for the gene therapy that really put the program on halt. But then subsequently, with the associated virus vectors, some improvement in vectors, they pursued it. But so you can see hepatic abnormalities, and it's often immune mediated. One, it could be vector related, or could be autoimmune mediated. So there's a lot of use of immunosuppression in the context of gene therapy. There are various strategies. Some people use immunosuppression on demand when the lipids go up. Some have a baseline platform of immunosuppression, pretty aggressive immunosuppression, tacrolimus, salvarimus, before they start gene therapy, because they're very nervous about severe hepatic manifestations. The sad, unfortunate part is, if you on demand use immunosuppression and drop the transaminases, there is a decrease in transduction of the gene, so they may lose gene efficacy. So the companies are struggling to see as where the balance is, and occasionally there's still liver failure issues after gene therapy. And then one other thing is that there might be I don't want to blow it out shape, but there are reports of cancer, HCC law after gene therapy. So there is actually a great need for hepatologists to become aware of it. In fact, we can review on this with an Indian mentee, and hopefully when it comes out, I'll share with the entire hepatology community on hepatic manifestations of gene therapy. So I just want to comment on that. Number two, the protein modified pig for transplantation. I know the first one was done in the heart, and the selection was not good, but the heart didn't last long, and then he talked about the kidneys. So we have done experiments in 3 dissident donors who livers could not be used, and we've done some extracorporeal perfusion of genetically engineered pig model to see the function in terms of liver function, cytokine profile, etc. The thing is, what we noticed is severe thrombocytopenia, and we don't know why severe thrombocytopenia is probably some sort of immune mechanism. So we need to work it out before we actually do a transplant. So the next step would be to identify
Briefly,
ACLF and see
points.
and bridge it.
Gene therapy, I think what Alok used 5 patients, I know they have done well. And I'm not sure after CRISPR cause gene transfer, how much immunotherapy. Your point is very valid, and we have to look for it. And I think in the next 1 decade, we should have organs, and we should be using them in the future, despite all odds. Thank you for the question.
Congrats, a very good proposition of novel findings and food for thought. A lot of food for thought also for your institute and our endeavors. I think it's really great. A very short comment on the also mRNA therapy for cancer antigen expression. I think there are some caveats because usually cancers have a potpourri of modified genes which can vaccinate against. And we have BioNTech next door. I know Moderna, for example. And I think this approach is still limited because tumors quickly lose HLA, expression of certain tumor antigens. And secondly, there's tumor evasion, even with a potpourri of 10 mutations for a single cancer which inject way into dendritic cells. I see a big future in modulating the tumor microenvironment and multimodal therapy. Checkpoint inhibitors are a very good approach in the proportion of patients There's other checkpoint-like switches that can activate the macrophages, cancer-associated fibroblasts, and other immune cells. I think that's the future, and that's what we are also interested in terms of the company. And serial transplantation, I see there is temporary success with pigs, modified. I see the major problem also is protein, let's say biochemists that performs a lot of foreign proteins, which we are not protected against when it comes to immune reactions. So I think that's a major problem, which is very difficult to overcome with pig organs. And then the micro-robots, I think, are pretty interesting because in a way we are also doing this with non-particular therapies. Of course, the robots apparently have properties of moving ahead in different pHs, etc., which is interesting, but we have already nanoparticles with similar properties where we put small molecules in. Preferentially go to the liver, which is a big advantage. Most nanoparticles go to the liver.
You approve micro robots, you approve it for future.
Yeah,
Out of my 10, you approve one micro robot.
it's tricky.
It's tricky.
Nanoparticles that move a little bit. I didn't see them move out the viaduct. You see them move out the
I couldn't get the video on that. I read the whole paper, but I didn't see the video. But I love to see if it can go up the viaduct without external endoscope, and if it can move the viaduct.
So, and very quickly, I think what is really a great development is this MRT, which apparently is a very cheap version, which can really have everything. Maybe you can comment on that a little more.
The MRI?
MRI.
Yeah, I think this is a breakthrough because normally you get a big room and all that, but here what they show was in a doctor's clinic, ultra low signal MRI, 0.05 Tesla. You can use it, and the scan is done in 2 minutes time. It's like your chest X-ray, everybody, and you have it, and your 3D machine learning can give you same image as if you have done a huge MRI with 3 Tesla. And I think if this is available, it should become a reality as a first screening tool for human beings. So to me, at least I will wait for the comments from if there are any from the audience.
Comments from the house?
So we at least have few things MRI which might come. Maybe the 3D printing of organs, which might probably be useful. I think the 4 types of capsules to collect the microbiota, that paper in Nature might be true. I think exosomes we see in reality is a huge area of work. These are plant-derived exosomes, extracellular vesicles, which you can prepare with 40,000 ultracentrifugation. So these EVs are the future therapies. You don't have to give injections, and I think mRNA vaccines are very much for cancer development.
So I see that the future is about research-based gene
There will always be problems. There will be always ways, but of course we have to overcome. And the future belongs to those who write their present well.
The concept of a genetic twin seems quite interesting, sir, but we understand that manifestation of any disease is an output of not only the genetic thing but the environmental things that a person is exposed throughout his life. So, how do you see the role of this thing, and how far will we be able to replicate the environmental things in that genetical twin?
So the genetic twin or the computer generated twin can change every day. You have your genes, you have your metabolome, you have your lipidome, proteome, all that is part of the digital twin. It's not the genes alone. The digital twin is a replica of 9th of February 2025. You just read in the data, you update your digital twin every day, and this is what is being done in many centers, especially in Norway. They're just doing digital twins. So you have your digital twin, and you say, today I want to take 30 units of insulin, what is going to happen to me? And your digital twin will tell you, these are the problems that you can face. So I think digital twin and everyone being able to make a digital twin is something which I feel with the AI coming in should be the reality.
Any questions from the audience?
So what about artificial blood using fetal stem cells? Artificial blood using fetal stem cell therapy. Artificial blood.
Artificial blood.
That at least will not have any of the other genetic side effects or.
I haven't read it enough, I must admit. But I think the synthetic blood, that is what you are trying to say, is a possibility where all the, at least the transplant worries or reactions can go down. I think it's a big discovery. I could cover 0.001%, whatever little I could understand. But to me, the alpha protein is number one of all the discoveries. That will change the way we will have protein-protein interaction. I know we used to do crystallography of albumin. We get albumin structure, keep rotating. Oh, it is 34 position, this will bind. The metal will bind here. Now you can do it in no time. With 200 million protein structures free available. Now you have single cell sequencing. You take one cell, and that one cell will give you complete atlas of all other cells of your body. This is called cell cartography. The cell cartography atlas published last year. You take one cell of my body, one somatic cell, and you can do cartography of remaining cells. You don't need an HLA and all. So I think the world is moving, but these products, unless we keep some understanding, we will be left behind. That's where I think I thank Akash for making me read and understand and put me on the spot.
So, thank you, Professor Sareen, for that insightful presentation. It's now time for a Build 2.0 oration. Please join me in welcoming our esteemed chairpersons, Dr. Ramesh Roop Rai, Dr. Satish Kulkarni, Dr. Prabha Sawant, Dr. Arun Vaidya, Dr. Sandeep Shah, and Dr. Nitin Naravane.
I welcome Dr. Julia Wenden to deliver the oration on current and future directions in acute liver failure. She's an authority on this subject and doesn't need any introduction.
Good morning, everyone, and thank you again for the opportunity to be here, Akash. I looked at my talk this morning and thought, gosh, I've put too many slides in. So I apologize. I'm going to talk quite quickly. Anyone who wants the slides is welcome to them. In this regard, I'm going to try and cover a little bit of history that hasn't moved on as well as perhaps it should have done, and a little bit of how I think we need to move forward and perhaps break some of our fixed beliefs in the management of this patient cohort. So characteristically, we think about acute liver injury, progressing to acute liver failure when you develop encephalopathy in association with your coagulopathy, and then we decide whether you fulfill transplant criteria or not. And we call this a homogeneous population, but we know it's not. It's not homogeneous at all. Subacute liver failure is, to me, totally different to acute and hyperacute liver failure. They have a different phenotype, they need a different management strategy. Most of the subacute need transplantation. The acute and hyperacute frequently get better without transplantation. So we really do need to rethink our world. In all of this, I want to pay real credit to colleagues over the years. My friend and colleague, John O'Grady, who developed the criteria that we still use today. And how life has changed. That picture, the top left, right. Sorry, I'm dyslexic and don't do right and left. That was the acute liver failure unit that I arrived to when I started at the King's Liver Unit. The modern version is below it. It's changed. What are the etiologies? This is history. It hasn't really changed much. But I think we need to start thinking about etiology in terms of, is this a primary liver injury? And is it subacute, or as I said, hyperacute acute? Or is it actually a systemic disease? And do we therefore need to treat this differently? And we know that there are sub-diseases within this, such as the herpes virus infections of pregnancy, which are a devastating disease, needing a totally different format of antivirals, which is still poorly understood. So I would suggest to you that we really need to think the paradigm of describing our acute liver failure syndromes, the etiologies, and the management. But what seems to hold fairly clear is etiology and severity determine outcome. And if you look here on the left hand of that diagram, most of those are subacute and they all need transplant. They do not survive well without transplant. To the right-hand side, these are your acute, hyperacute, and as we modulate our management techniques, we should be able to get these patients to survive with their own livers. And let's none of us pretend, however much liver transplantation is wonderful and saves lives, that it's a healthy existence. We are changing one disease for another disease in terms of cardiovascular and long-term morbidity. So we need to consider that in our decision-making process. And of course, within the Indian subcontinent, you have your own population of acute liver failure. The rodenticides, the hepatitis E, the growing hepatitis A. This data needs to be derived for your populations with your genotypes, with your epigenetics and various omics. Europe has its own, USA has its own, South America has its own. We've got to be both international and regional local, and we've got to develop that skill. So what do I want to cover? I've talked about my prejudices, about the definitions, and hope to review that shortly. I think we need to focus on that initial resuscitation. Time is tissue. It's a trauma saying, but it holds for acute liver failure. If you delay in your diagnosis, your resuscitation, treating the reversible and transferring to an appropriately large transplant center, you will be doing detriment to your patient. We all like looking after sick patients and feeling we're doing well, but big centers with big volumes are where these really sick patients need to be. We need to address their cardiovascular status, their respiratory status. We need to screen for sepsis and inflammation. You know, if there's one thing I would love to be able to finish my career with, it's doing a bit more to separate true sepsis from inflammation. We mix the two horrendously, and we make mistakes because of that. The neurological management is improving, but your phenotype is different from the phenotype I see, and it's still more prevalent for you. we need to look at the metabolic and the renal status. And I will talk about the phases of illness as your immune system changes in the face of an insult. We need to look at that, we need to assess that regularly, and we need to change our management dependent on the immune status of the patient in front of us. So what you do on day 3 is not the same as what you do on day 5 or day 7. Sorry, these slides are moving. Right. Again, this is an old slide, so I'm going old and new. When someone is a bit sick, move them. Transfer teams that were developed during COVID, certainly in the UK, have revolutionized how we manage sick patients. Having a team that goes out, retrieves a patient, and brings them back in a good condition is amazing. And it has improved the outcome. And I think we'll show that data. So transfer is essential. If their neurology is deteriorating, intubate preemptively and control the airway. Observe the pupils regularly. Give some fluids. I'm going to talk about that in a minute, but I always carry normal saline for the first 2 liters at least. These patients have been vomiting. They're chloride. Apologies. I'm too short. I need to grow. Normal saline. Most patients who are sick are vomiting. They've lost chloride. They've lost sodium. Replace it, but avoid hyperchloremia. Always travel with something for big dilated pupils. I use hypertonic saline, either 3% or 20%. It's easier to use, but if you want to use mannitol, you can do. And treat the reversible. I did my initial research with N-acetylcysteine. It was fantastic fun. I thought it should be in the water. It's a fairly benign drug. It's multifaceted. It replaces cyclic GMP, glutathione. It's a sulfhydryl donor, really important for your vasculature. And it improved outcome and organ dysfunction. But, and this is a real but where we always need to go back and break the tablets of stone. If I did that research now, I would put you money on it, it would be negative. Because how we managed those patients then was sodium is to their detriment. They all got dextrose because they had liver failure. So I think what I was doing was resuscitating those patients and giving them a sodium load. So always look at why you did something and what the benefit was. So I still use it. I use it for about 5 days at maximum, and then I stop it because it's an immunosuppressive agent. Switches off NF-kappa B. If you use it after day 5, you are contributing to the immune suppression that your patient then has. So be considerate. Lactate is a really useful marker of both liver failure, lack of resuscitation, but also accelerated aerobic glycolysis. These are sick, inflamed patients. It doesn't mean they're septic. It doesn't always mean they're underfilled. You need to be the clinician at the bedside. You can't just read a book and apply it. You've got to be there and determine the right management. Coagulation, we've heard lots of presentations about. The bottom line is, look at the coagulation profile. Don't replace unless someone is actively bleeding. It's beautifully balanced. The patients who bleed, I would say as a grey-haired oldie, are those that are oozing from their mucosal sites, those with a platelet count probably of below 20, and those with a very low fibrinogen. Those are the ones that bleed. The others don't. You can get away with most things. The cardiovascular status. It needs assessing at the bedside. You put a central venous line in. You look at the pressure if you want to. There's actually some really sexy stuff you can do about delta CVP changes to a small crystalloid volume challenge. But you also look at CO2 gap and various other metabolic gaps across venous and arterial circulation. You give enough fluid so that they are reasonably filled, but not overfilled. Start vasopressors early. Do not volume overload your patient. Use invasive monitoring in anyone who is really sick. It goes against the strict rules of the game, but do so. Be sure you have someone who can use echo and ultrasound well to determine fluid responsiveness. What blood pressure? I have no idea. When I was younger, I was very arbitrary about things. By and large, I believe flow is more important than pressure. So I'm a low blood pressure person. But I can't provide you the evidence definitively, but all of the general ITU work looking at increasing blood pressure causes detriment. So probably a lower blood pressure is more sensible. Always think, could this be hypoxic hepatitis? To the right of this slide, you see a CT scan, the ultrasound showed the same. Big hepatic veins, that's right heart failure. 1, you want to diagnose it. 2, avoid a high right-sided pressure. It is not good for a struggling liver. Some patients actually present with acute liver failure as hypoxic hepatitis. This young man did. As you can see, he fulfilled transplant criteria, but actually he had a viral myocarditis. That was his primary disease. He was treated with VA ECMO, and he survived without a liver or a heart transplant. So please be considerate. In highly selected cases, we use VA and VV ECMO for our acute liver failures peri-transplant. But it's a high-risk game, and it should not be gone into without real experience and consideration. We have heard beautifully from Prof. Sarin about albumin in the earlier presentations. So other than to say, I don't use albumin, and if I'm being foolish, I say it's because I can't squeeze it. It comes in a bottle. But the reality is, in resuscitation, it probably does not have a role. And we've heard that in the critically ill, there really isn't an evidence base to give it. Do my colleagues occasionally give it? Yes, they do. When their back's against the wall and they're 10 litres up on the fluid, they will occasionally. But it is a rarity, not a standard. And what's more, that statement from Prof. Bernardi that a lot of the albumin we infuse is not good. It's actually possibly pro-inflammatory, doesn't have antioxidant capacity. Let's really think about it. I would also draw your attention to this data. So this is data looking at various types of fluid used in a general ITU. But acute liver failure should learn from general ITU. General ITU should learn from acute liver failure. Let's not run in silos. And what this beautiful meta-analysis shows is that by and large, balanced solutions are better for you than chloride-containing solutions. But if you have head trauma, chloride and sodium-containing solutions are better. That's on the little red far right of that graph. So for our acute liver failure with cerebral edema, what do? I give saline initially, and then I give a mixture of balanced solutions and Hartmann's. I keep the sodium up so they don't become hypotonic. I make sure they don't get hypochloremic, and I occasionally, if I need crystalloid, use 1.23% bicarbonate. But you've got to personalize it. You can't just write a flowchart. And we must remember, as Vishali Salar told us the other day, to de-resuscitate. Fluid overload, gross peripheral edema, a congested liver is bad for your liver regeneration. So always think, what's the total fluid balance? Can I take some fluid off today? How am I managing my fluid? Is small print really important medicine? Norepinephrine remains the first drug of choice. And all of the evidence, as I said, is go a bit earlier on your pressor. It improves your venous capacitance. It squeezes venous blood into the central circulation. That's what we want. You don't want cold peripheries, but you want a bit of pressure and a bit of fluid to balance it. I use vasopressin once I'm up to 0.3 mics per kilo per minute of norepinephrine. This is the VAST study. It suggests that it's safe, and it might even be a bit better for those with renal failure. But I always start with norepinephrine and then add vasopressin. But sometimes you're up to 0.7 mics per kilo per minute. You're pouring fluid in. Life is not looking good. What I use then is either methylene blue or high-dose hydroxycobalamin. Now, methylene blue is very different to the old era of LNMA, where you got total blockade of nitric oxide. This is blockade only of inducible NO. And therefore, although all of us are a bit worried about using these agents, on occasion, they are really useful to get you out of trouble and begin to restabilize. You only give it twice, 70 milligrams, followed by 70 milligrams, 1 mg per kg. But it is worthwhile. Small meta-analyses, I would suggest you ignore them. There's much too small a number of studies in it to be useful. But it's a drug to have in your back pocket. This is the methylene blue data, and again, useful drug. It doesn't have the joy of turning the urine if you've got any green, which is great fun for students, but it is also a useful compound to get your blood pressure up. Do you use steroids still? Well, I still do. I use hydrocortisone for vasoplegic shock. I should, and I do, use fludrocortisone as well. Because again, this really good meta-analysis suggests that it is that combination which induces a mortality benefit. So I don't know why it works, but if you're going to use one, use the other, please. Is there adrenal suppression in these patients? I don't think there is, actually. I know that the ACTH tests are all low response, but if you look at the beautiful work of the Lurvin group, which you see in the right hand of this slide, there isn't evidence of adrenal failure, but they respond to hydrocortisone. So we don't quite know why that is. I show you very old work of a colleague of mine, I supervised a PhD years ago, of Rachel Harry, looking at the role of steroids in acute liver failure. It improves your response to vasopressors, it doesn't improve mortality, and there's a risk of increased multi-drug resistant infection, a big issue for yourselves. There was a strong correlation with cholesterol, not unsurprising given you've got liver failure. And then you take that the next direction, and using the really big biobanks that many countries have now set up, and going through the big databases related to some of the big research studies, you can actually show that cholesterol, low cholesterol, is a risk factor for sepsis and a risk factor for mortality. There is so much we do not understand about the basics of physiology, metabolics, and how we all respond, both genetically, metabiomically, and epigenetically. And I think this is fascinating work for the future in how we might develop risk profiles and modulation. Feeding, difficult one, isn't it? So when you've got your encephalopathic patient who's not yet intubated, don't put a nasogastric tube down, because if you cause nasal bleeding, you're going to cause harm. If they'll take some forceps, some fluids, some food, fantastic. I don't push it. They have a risk of pancreatitis. Be aware of that. Data from the Japanese data clearly shows the worse your liver failure, the worse your risk of pancreatitis. Always consider, always CT. Our surgical colleagues don't like it when we send someone for liver transplant and they've got a horrible necrotic pancreas, which we haven't diagnosed. So think about it. The respiratory distress, again, I find this fascinating, and it's a real sadness that there's only about 1 or 2 papers on acute lung injury and acute liver injury. And the reason is that by and large, it doesn't happen together. So any other acute ITU patient who is as sick as an acute liver failure patient should have ARDS. Our acute liver failure patients don't have ARDS. They don't get ARDS until their liver starts getting better. So there is something about liver failure that is protective to the pneumocyte. We need to find that, and we need to explore it for our other patients. Absolutely fascinating. But the data actually shows us that when you are critically ill, protein loading someone for that first 7 days of critical illness is detrimental. So please, do not think that you've got to put the nasogastric tube down. you've got to feed them either enterally or by TPN. Actually, you don't. You can just relax. If they absorb 10 to 20 mils of feed, fantastic. If they don't, chill. Get it going by day 5 to day 7. This was amazing. Not only did it not improve mortality, it didn't improve functional reserve either. So it's not as though you're improving things post-discharge. So there's a real opportunity here to think differently. And this really excellent work from Zudan, looking at sick patients and protein synthesis, and however much protein you give them in the early stage of critical illness, actually it's associated with increased muscle wasting. So again, it goes against what we think we should be doing, but let's throw out those tablets of stone and think again. Stress ulcer prophylaxis, beautiful data from Deborah Cook suggesting, yes, we should use it. But then I reflect on a talk earlier in this meeting suggesting that PPIs are really bad for your risk of development of multi-drug resistant infections. So maybe we should use them for a week and then stop them as we get the enteral feed going. I think, again, we need to be braver in this. We need to think about using other agents with less side effects, such as sucralfate. I'm going to start talking faster, I do apologize. Cerebral edema. It is now relatively rare for us, but it's still a problem in the Asian community, and we must recognize that. Some of it might be a different disease phenotype, some of it might be a younger age population, some of it might be perhaps later transfer to specialist centers. What's important is the patients who are at risk are the young and the inflamed, not the septic, the inflamed with an inflammatory phenotype and with renal failure and a high ammonia. And those that don't respond to initial resuscitation with a drop in ammonia, that's your high-risk group. Now, we have by and large stopped putting in ICP bolts. If you read the literature, everyone says it's not worth it because it doesn't change outcome. Well, monitoring never changes outcome. It's what you do with that monitor that changes outcome. So if you want to carry on doing well-designed studies that look at how you manage cerebral edema and intracranial hypertension that is resistant to standard therapy, you need to put in an ICP bolt and you need to standardize the management and look at the outcomes. Age is important. Old slide again. You see that I am at no risk of cerebral edema. My brain is shrinking rapidly. But the young person is at significant risk. And that was described back in the 70s by Dr. Ware. And ammonia is important. To the right of this slide, you can start looking at extraction of ammonia across various beds. Your lungs exhale ammonia, your brain extraction of ammonia, your muscle extraction of ammonia. If you've got a really hyperammonemic patient, look at that and modulate it as best you can. Keep them cool, 36, not cold, but cool. Keep their sodium between 145 and 155. Go up in increments. And as you go up in increments, as they get better, come down at the same rate. Don't come down rapidly, you'll cause damage. Come down slowly. Renal replacement therapy, it's a water-soluble toxin, it facilitates clearance. I use diafiltration rather than filtration. I rarely go above 5 liters an hour, just because the machines don't like it. But it's a clear linear relationship between urea clearance and ammonia clearance. So what do? I measure ammonia, normocapnia, normothermia, sodium as I've discussed, blood pressure of 60. If you've got an ICP bolt in, you can see whether they're autoregulating. Without that, you've got to be sitting there with a transcranial Doppler looking at the pressure changes. And there's a lot of inter-observer variability in that regard. I use CT scanning only if I think they've got an intracerebral bleed. And sometimes you still need an ICP. You can use optic nerve disc, but it's got a higher incidence of variability. Okay, infection, big deal. Inflammation, big deal. Professor Roger Williams, my mentor, did vast works with this, as did Nancy Rolando. And what's really interesting, if you go back into old literature, fresh frozen plasma, which is what we give when we do plasma exchange, is great for fibronectin replacement and improving opsonization. So not only does it improve your microparticles and your microthrombi and your organ dysfunction, it probably improves infection. And yet we all get worried it causes infection. The sepsis literature suggests plasma exchange is good for sepsis. The biomarkers are not as good as we all think, as you see from this data. They are not good at separating severe inflammation sterile from inflammation bacterial, inflammation viral. So we need better markers. We need to think about infusions of antimicrobials rather than boluses. This data suggests clearly that they have benefit on the big meta-analyses. It's the area under the curve that seems to improve killing of organisms rather than the bolus peaks. So consider changing your modalities. But also consider that the antibiotics we give are really detrimental to the microbiome. You see here this data for tazocin particularly showing loss of microbiome, change of butyrate, risk of systemic immune paresis. What we do on benefit on one side might cause harm on the other side. And indeed, data looking at critically ill patients treated with cefepime versus tazocin, actually there's a benefit to the narrow antimicrobial of cefepime. So something to think about. And again, a mortality benefit. So they are immunoparesed, these patients. At their very early stages, we hear about cytokine storm. It's true in the early stages, they're inflamed. Some of them then become immunoparesed. We just describe it, we don't measure it. You can't say that someone has a cytokine storm or is immunoparesed unless you're measuring it. And we know this is dynamic. This is work by my colleague who sadly died much too young, Harry Antonides, which looking at HLA-DR, showing the differences in various parts of the liver. I'm going to skip this for the sake of time. We can alter these observations with agents such as SLIPI and manipulating Merck-T positive or minus in terms of immune modulation and liver regeneration. For me, that is where we will be going soon. I apologize, ladies and gentlemen. This is the plasma exchange. This is why we did it, because when we put healthy monocytes in sick acute liver failure plasma, my monocytes became immune paresed. So we clearly had to change something in the plasma. It was as simple as that. These are the last few slides I want to run through with you, colleagues. This is a lovely review article by Jean-Louis Vincent saying, this is how we used to do studies, and we haven't found positivity by and large. The future is really looking at the patient in front of you and based on pathophysiology and biomarkers determining entry into studies. If we go back and look at some of the big studies, this is general ITU literature, and retrospectively separate them into inflamed versus immune paresed, you can get a reasonable degree of separation. And then you can start saying, gosh, actually the outcomes are different for the various groups. And the manipulations result in a different outcome. So you see here, these are the ARDS studies. Hyperinflamed, hypoinflamed, very different outcome and very different treatment options. Similarly, for this big study looking at valid and early, reasonable number of biomarkers that were used to separate the groups. Really interesting. You can then separate them again into this inflamed group, the hypoinflamed group, and again, you show a mortality difference across the groups. So this is where we've got to be going in acute liver failure. And for something like activated protein C, that had all the physiological reasons to work, but was a negative study. If you do that with this group, this is what you show. you can show, I don't know where the mod thing is, but they've taken my slides away. What rotters? Okay, what you can show is they're back. So you can show there is a group who will benefit and there is a group that will not benefit. If you put them all together, you fail. But if you separate them, we might really start winning. So, colleagues, where do we need to go? We need to separate our patients into those who will benefit and not benefit from the interventions we take. Otherwise, we are back in the dark ages. We really need to step forward. What might that be? Well, we heard about nivolumab in terms of cancer. For our immunosuppressed patients, that's what we should be considering. And we're now doing a pilot study in that, and Europe is starting an interferon study as well. And if you look at it, we've done a bit of work in liver failure. You can see the references there. This is in ITU patients. You can improve HLA-DR. By about day 90, you've still got improvement. So one intervention, you might really change the moment. This is anakinra, didn't have a mortality benefit, but again, if you separate the groups, you begin to see that trigger. So monitoring of the future is HLA-DR, lymphocyte counts, doing lots of things, and most importantly, looking at the phase of illness that our patient is in. My apologies for overrunning. Thank you for allowing me my last few slides. Sorry? You want me to cover 2 sentences? Okay.
Thank you so much, Professor Wenden, for the memorable oration. I request the chairpersons to please step forward and felicitate Professor Wenden. Just the felicitation. Thank you, everyone. Now let's dive into an interesting panel discussion on confusion around the nomenclature NCPF, PSVD, NRH, INCPH. The moderator for this discussion will be Professor Akash Shukla. I also would like to welcome the distinguished panelists, Professor Shiv Sareen, Professor Dominique Wala, Professor Patrick Kamath, Professor Patrick Northup, and Professor Virginia Hernandez-Gaya. Please join me in welcoming our moderator and panelists. Thank you, sir. Your oration will be after.
Yeah. It's a break, right? So do we stay here or you just monitor? We don't need to stay. No, you don't need to.
So good morning, everybody, and welcome all the panelists here. I think despite my weight, I think the real heavyweights are that side. So we'll be talking about confusion around the nomenclature, NCPF or PSVD. So this is how things have started and evolved over the last 7 decades, starting with NRH, and then hepatoportal sclerosis, IPH, OPV, NCPF, IPH, pre or early NCPF, INCPH, and then finally PSVD. So this was one of the early articles in JAPI in 1976, which was titled as non-cirrhotic portal fibrosis, idiopathic portal hypertension in India. So, and now this paper was published in Lancet 2020 by the Waldeck Group, which talked of portal hypertension in the absence of portal vein thrombosis and without cirrhosis, with mild or moderate alterations of histology, is being increasingly recognized. So that was the interesting part. And owing to the heterogeneity of causes and histological findings, a subsequent number of terms and so on and so forth. So we'll start with Professor Dominiquala. What's the reason for coining this term PSVD, and why did you discuss, and why was it called PSVD?
So the reason for coining this term was that we wanted to expand the scope of the previous entity. The previous entity was mostly based on the fact that there was portal hypertension, and we wanted to include patients with exactly the same lesions, but without obvious portal hypertension. And this could not be done with the previous terminologies because idiopathic portal hypertension contains the terms portal hypertension. So that was the first reason. But we wanted also to expand to include patients with a portal vein thrombus. I do not say cavernoma. I say a thrombus in the portal vein who were excluded from the former definitions. And the third reason that was we observed exactly the same lesions in patients with Hep-C or Hep-B or other causes for liver disease, and they were also excluded from the former definition. So we had to modify the definition, and because we modified the definition, we modified the name, of course, because there should not be any ambiguity given with the name. And then why this name? Because there is really a complete consensus, to my view, on the fact that the primary lesions is sclerosis of the portal vein and the neighboring portal space, and sclerosis of the sinusoids. I think that all the literature coming from Japan, India, US, Europe, turns around these lesions. So portosinusoidal disorder was felt to be a good name. As usual, it's never a perfect name.
Thank you very much, and I think these are the points that we are going to discuss really in the next 15 minutes or so. So this is how APASL has given the classification of portal hypertension with intrahepatic causes, clearly identifiable etiology, where etiology is not evident, NCPF, and then the variants, the nodular regenerative hyperplasia, partial nodular transformation, and incomplete septal cirrhosis. So I'll come to you, Professor Kamath. Can you explain what is this nodular regenerative hyperplasia, how to diagnose it? Because this has been a big enigma for many people out here.
Thank you, Akash. So nodular regenerative hyperplasia is classically a histological diagnosis. Areas of atrophy best seen on reticulin staining and no fibrosis. So there is a clinical presentation. We suspect that when anyone has portal hypertension and the liver otherwise looks normal, patients functioning by liver biochemistry, only minimal abnormalities. So you can make the diagnosis on histology. The question we asked ourselves is, can we do it non-invasively? We don't do a lot of fibroscan, we do a lot of MR elastography. And so we take a spleen to liver stiffness ratio. And so the liver stiffness is not in the cirrhosis range, the spleen stiffness is increasing. But this is associated with many different conditions. So we did the long-term follow-up of these patients. We called it primary NRH, where we couldn't diagnose a specific etiology. It doesn't mean that it wasn't, it just means we were not smart enough to diagnose. And then we knew there was a specific etiology. We call that secondary NRH. Secondary NRH do badly. You know, they've got a 10-year survival of only about 40%. So there's a big difference between the two. So I think the associated etiology makes a difference. If you transplant these patients, they seem to have done well. We did not see recurrence of NRH post-transplant when we did these patients, and these were primarily for primary NRH. You do see NRH occur post-transplant. If it occurs early, typically within 4 years, it's almost always a vascular problem that occurs. If it occurs late, I don't know what that means, but we really don't see much. And that is probably what is PSVD. And finally, if you look at the 3 histological features of PSVD, NRH is one of them, obliterative portal venopathy is 2. So these patients whom we are talking about did not have the portal venopathy. So whether obliterative portal venopathy behaves exactly the same as NRH, I don't know. The third histological feature is the so-called incomplete septal cirrhosis. I'm not sure what that entity is. I've not seen a lot of that.
Great. Thank you. Thank you so much. And so one of the points which Professor Dominic talked about was that if you have, they wanted to include patients with no portal hypertension and as part of the same, and that is the reason why they coined the term. So in the recently published paper, different stages of NCPF/IPH have been published. So stage 1, no discernible portal hypertension. Stage 2, probable portal hypertension. Stage 3, uncomplicated portal hypertension. And stage 4, portal hypertension with complications. So, Professor Sareen, can you explain the need for these newly described stages of NCPF/IPH? And do you think when you talk of patients with portal hypertension and without portal hypertension, are these two separate diseases, or is it different stages of the same disease? And that's why, do you think we really need a new name for this disease?
You go back to the previous slide.
No,
previous slide. Yeah. So the question is very clear. First, we need to differentiate NCPH from NCPF. What Dominique was saying was that every patient with non-cirrhotic has portal hypertension is not correct. The terms are non-cirrhotic portal fibrosis to differentiate it from cirrhosis. So non-cirrhotic portal fibrosis can have 4 stages, and the first is pre-NCPF, which was described in 1989. So there is no discernible portal hypertension, but yes, there is some amount of portal and other fibrosis, and yes, there is an element of obliterative portovenopathy. Then over a period of time, these guys get probable portal hypertension. Then they have complications, as you will show in the next slide, maybe you can show. And then there is a portal hypertension with its complications. So the need to clearly, we grew up, and many of these people who grow up here, they can say a patient who has a spleen, has a bleeding, he has non-cirrhotic portal fibrosis because he has no decompensation, no jaundice, he has a stable liver. But there are patients who have no splenomegaly, but the liver biopsy feature. So the need, whether we need a PSVD because the non-cirrhotic portal fibrosis had to have portal hypertension, probably is not correct. I'm not trying to debate on what the European Baltic group says, but also I would like to say, since I have seen the autopsies of these patients or those who have gone for surgery, the liver looks plumb normal in them, and only there is a periportal fibrosis. I also would like to say that every patient who has got hepatitis B or C or MAFLD or MASLD, they may have similar features. We need to see, we are seeing a patient rather than seeing a microscopic or a biopsy features and then going back to the patient. So therefore, there is some debate, and I would like you to go through these 4 stages very clearly. So there is no necessity of portal hypertension in the pre-NCPF stage.
Thank you very much. Also, the second point, which for justifying a new entity of absence of portal vein thrombosis cannot be an a presence of portal vein thrombosis cannot be an exclusion. I think even in the 2007 APASL NCPF IPH guidelines, it was mentioned that portal vein thrombosis is common in patients with NCPF IPH, and it portends a worse prognosis and is considered an advanced stage. Now, here I think we have
One
gotten
point I would
confused.
like to say, Akash, in the only original beautiful paper of 702 portal angiographies which were done by Kunio Okuda's group, they published in Gastroenterology in 1987, saying that cirrhosis has portal vein thrombosis 0.5% and non-cirrhotic portal fibrosis, their IPH is 1.5%. And then we all, I mean, the Japanese group and we, there was a Japanese Society of Portal Hypertension. They followed about these 700 patients. And we in India followed about 2,900 patients. And over a period of 10 years, 10 to 15% of them who had a portal vein patent developed portal vein thrombosis because of shunts and other. But to have a priori inclusion of portal vein thrombosis makes a difference because these are probably two distinct diseases. They start with portal vein thrombosis and get portal hypertension. Somebody has portal hypertension or dilated portal vein and then they get.
Absolutely. So what sir is trying to say and what I was trying to convey was, what is the starting event? If your starting event is portal vein thrombosis, then we know over a period of years, you will get sinusoidal changes. And if you do the biopsy in this patient after 10 years of portal vein thrombosis, 5 years of portal vein thrombosis, you will get changes in the sinusoids. You will get changes in the portal area. And then by today's definition of PSVD, you will actually call these patients as PSVD. Whereas the primary event was portal vein thrombosis. They never had any intrahepatic pathology to start off, a pre-sinusoidal pathology other than portal vein thrombosis. Whereas, on the other hand, including portal vein thrombosis as a complication of a primary portal sinusoidal pathology is different, because that is possible and that happens. And that is what has been demonstrated in the last 4 decades. So you start off with a pathology in the porta and the sinusoids, and then you get portal vein thrombosis as a complication. That is what is actually what has been documented over the past 3 decades. So this is what Boveno gave. It's a broad clinico-pathological entity encompassing all the terms that we have talked about, which are histological terms and clinical terms. I'll not go through this again because I think most of it we have already discussed, was comparison of the 2007 guidelines and the new proposal for PSVD. So coming back to Virginia, do you think PSVD, can it be really called a novel entity, or is it a novel name to a pre-existing entity with some additions?
Well, I think that it's too clear to everyone that it's not a novel entity and we are speaking about the same. What is new is the concept of having like all the patients under the same definition, under this umbrella term, to really be able in the future to gathering all these patients and study them. I completely agree with what has been previously said. We don't know how the evolution is of these patients, and sometimes we do the diagnosis probably very early, but sometimes we do that like late with portal vein thrombosis and so on. So are we speaking about the same? Are those patients with one lesion or another histological lesion the same? What is the role of associated conditions? I think there are like many things that we still don't know. But what was new, if you want to call it, is like the concept of putting everything under the new umbrella term. The thing that is new is the term, but not the disease. And we have reports coming from the 50s, so it's nothing different that we have in Europe.
Thank you so much. So, Professor Kamath, do you agree with what Virginia has just said?
No, I agree. I think it's exactly the same position. We don't know what this is. Looks like there are many diseases which are associated with that histology. So is that histology driving the disease, or is that just a bystander? We don't know. Because to me, again, it's from the patient point of view. The presentation is quite different in these patients, from severe pulmonary fibrosis, hepatopulmonary syndrome. I don't know if any of you have seen patients who are treated with trastuzumab. It's the HER2 positive for breast cancer. They get a terrible portal hypertension extremely rapidly, hepatopulmonary syndrome, and they've got this histological lesion. To me, I really want to find out what that histological lesion is due to. If I can stop that, we can help patients. So I think it's a term which is the basis for future investigation. To me, it's not an end point of anything.
Thank you. Coming back to Professor Dominic, the heterogeneity of the disorders, like Professor Kamath also just talked about, actually causes confusions about this term PSVD in the practitioners. So can you just simplify, as a practitioner, when should they really think, okay, this could be PSVD? How can you simplify the whole algorithm to clear the confusion, because it's too heterogeneous?
I don't see really the heterogeneity compared to, for example, Hep-C, Hep-B, alcoholic liver disease, non-alcoholic steatosis. Every entity has a scope. And here the only heterogeneity for the practical message is, are there signs of obvious portal hypertension, meaning collateral portosystemic collaterals or not? That's the only level of heterogeneity. For the rest, of course, it's a spectrum of disorders. There are many associated conditions. We don't know the relationship with the lesions, but at least we have lesions that can characterize the entity. This is very important. In the past, it was non-cirrhosis. It's still important, but in addition, we had that we want lesions in the microcirculation. But again, Hep-C is very heterogeneous. There are patients with and without portal hypertension, and we don't discuss that it is an entity. So what we propose is based on the microvascular lesions. It is an entity for which we have to study prognosis, course, etiology. We have a lot of things to do to better characterize this entity. But the main level of heterogeneity, and for me it's not, for liver disease, there is or there is no portal hypertension visible.
So you have been very quiet. So, Patrick, how often do you suspect PSVD in your clinical practice in the absence of portal hypertension? And what is the term which you have been using for patients with portal hypertension and patients without portal hypertension?
Yes, we use the term PSVD mainly because it's what we've been exposed to over the past several years. I suspect it. I see a lot of patients with portal vein thrombosis. I suspect it when I can't find an etiology for portal vein thrombosis in a patient who I'm seeing even with, without significant portal hypertension. So if we've excluded the hematologic malignancies, the other common causes, the anatomic issues, I suspect that a good number of these patients have PSVD or have had PSVD for many years and just weren't diagnosed. I do want to comment on the heterogeneity. I've been thinking a lot about this, and I have my concerns that some of at least the histologic heterogeneity is maybe attributed to how we're obtaining the liver biopsies in these patients. When I am trying to diagnose cirrhosis or not in a patient with portal vein thrombosis or with portal hypertension, I obtain the biopsy at the time of the HVPG via a transjugular approach. Whereas when I'm sent a patient with abnormal liver enzymes or without portal hypertension, their diagnosis from biopsy is frequently done percutaneously. And we know that vascular liver disease does occur heterogeneously within the liver. So perhaps some of this is artifact of how we're achieving these biopsies. So I think we have to think about that when we categorize these patients in the future, and even paired biopsy samples in a research setting might be useful.
So, thank you. So for me, I think I become uncomfortable when I say a patient with trastuzumab-induced, I call it trastuzumab-induced hepatopathy, and a person who has got portal hypertension because of telomere shortening. And I have another patient who comes to me with a big 15 centimeter spleen who has had 4 well-tolerated, untreated variceal bleeds in the past, to put all these 3 of them in one diagnosis. I become very uncomfortable because I don't think they have the same prognosis. So unless we have very well defined starting points, which may be varied and diverse, but if they are converging towards the same outcome in the long term, then I think we are justified in grouping them all together. But I think we still do not have enough data that all these entities will converge and will have one prognostic or therapeutic pathway. So I think the jury is still out on that. Yeah, Dominic, you want to say something?
There are 2 points which I want really to emphasize. The first one is the difficulty to make the diagnosis on a needle biopsy. It has been very well documented. We need a large sample, we need several samples to find the lesions, first one. And the second one is that I find the classification, the last classification from the NCPF, IPH, very useful. The only reservation I have is that I don't know if there are successive stages. That's the only reservation. So it would be types, it would be variants. I would prefer the terms variants, but I like it very much, and I think we should incorporate this in any new revision of our classifications. For the rest, I really think that NCPF, IPH 2024, as I said, the new definitions, and PSVD is virtually the same entity. I really think that. And I think there is no problem having 2 names for the same entity. What is a problem is having one name for 2 different entities.
Thank you. I thank Dominique for having accepted the Asian version, and your appreciation means a lot to all of us that this new 2024 consensus led by Akash is useful. I have 2 points to make. One is you start with a pathology. In a way, you are outsourcing your diagnosis to a pathologist and go to a patient, but normally it is generally the reverse. So the strength of the non-cirrhotic portal fibrosis is the clinical and the pathological part, not a pathology and going back. And number 2, if you ask me what is the best definition for portosinusoidal, it should be the vascular disease in that region where we have no other definition, because the non-cirrhotics, they stop at the 3rd branch of the portal vein. They don't go beyond into that portal area. I think the pure definition of portosinusoidal vascular disease should be limited to that zone, like you have sinusoidal obstruction and others on the other side. On the portal vein side, we don't have a definition before the portal vein. We have a definition outside the portal vein in SOS syndrome or whatever it is. So I think PSVD, if at all, as a pure niche area, should be limited to that. If you include everything, it will become like an ACLF, ACLF, decompensated, compensated, pre and post. So if you want a pure definition which everyone can identify, I would like to say we should be restrictive. Maybe typing of PSVD 1, 2, 3, 4 can be the future way.
Yeah. Virginia, you want to
If
say?
I may something, maybe we can discuss about what is the best name. I'm not sure we came with better terminology, but what I think is that we are all the time discussing, we don't know if those things are the same, if all these subgroups or variants are the same, but we do not know if they're different either. So for me, like, the important thing is let's recognize all the patients, because there is a lack of awareness in many places, and I'm happy to see that if something we achieve with the PSVD nomenclature is the number of papers that we have been citing or conducting after that, and the controversy raised attention to the field that we all love. So I think that what we need is to really make people aware, to really make our pathologists look at the biopsies and at the explants with these eyes, trying to identify the lesions. And then it's on us describing and being able to identify the subgroup of the patients, the evolution, the prognosis, and making the classifications. And also probably basic science will give us the information that we need about what is the responsible cell triggering the thing, and what is the phenotype, and what are the signals, and if they are like different in patients with or without associated disorder, with this or with that one histopathological lesion.
Thank you. So we'll take the questions once we finish the questions which are predefined, and then we'll take those up. So Professor Sarin, we talked of several terms here. So for you, which is a clinical term and which should be used only in histology?
Well, the clinical form generally, I mean, it is good to have the natural history from pre-NCPF, but like in hepatitis C, F2 can reverse to F1, F4 can reverse to F3. Similarly, if there is a change in the insulting area, then I think the non-cirrhotic portal fibrosis can also regress. We have seen over the years, 4 or 5 decades of seeing. Which clinical diagnosis I would still prefer non-cirrhotic portal fibrosis. So a clinical phenotype of that is a patient who has got probably spleen with or without collaterals like stage 2, or has got varices but has not bled, and this patient has a biopsy which is looking like normal except there is some periportal fibrosis, and you do a HVPG, which I think is vital, and this patient has got near normal portal pressure, and or you do a liver stiffness measurement which is normal but the spleen stiffness has gone up. So I think high spleen stiffness, near normal or normal LSM and HEPG being normal is a vascular disease. On biopsy, you don't see a readout of fibrosis. You do a what you call ELF score, and ELF is about 7 or 8, so there is not much fibrosis. So I think I would not go and do biopsy, everyone. I would now do a liver stiffness and a spleen stiffness and see these patients.
So thank you, sir. So these were the diagnostic features for PSVD. You require either one feature specific for portal hypertension in the absence of exclusion of cirrhosis and other causes of portal hypertension, at least one histological lesion specific for PSVD, and third interesting one was one feature not specific for portal hypertension with at least one histological lesion compatible although not specific for PSVD. And if you see, these are the specific features of portal hypertension. Interestingly, the non-specific features are ascites, thrombocytopenia, and splenomegaly. And of course, histological lesions, Professor Kamath has already enumerated. The non-specific ones are portal tract anomalies like dilatation, multiplication, non-zonal sinusoidal dilatation, mild perisinusoidal fibrosis, architectural disturbances, etc. So, Patrick, how often do you get any of the specific histological features on this needle biopsy? I think briefly it was talked about earlier.
Yeah, I don't think we know. We have given our pathologists a education on this disease, and our routine clinical pathologists are now identifying these lesions more and more. I think in the past, at least in our center, they were called drug-induced liver injury. And indeed, some PSVD or portal fibrosis is due to a drug-induced liver injury. Often we would go back and give the patients the third degree and really try and understand what supplements, whatever they were taking, and they would deny any of them. And so I think we probably, now that we're looking, are seeing them more and more, especially in these patients with unclear abnormal liver enzymes, unclear portal hypertension etiology, and no suspect drug exposure.
Thank you. So, Virginia, what is the reliability of the non-specific features of portal hypertension and PSVD?
Well, this is like the very tricky question, right? I mean, no one will doubt that if you have a patient bleeding with varices, you do the biopsy and then you don't find anything, or you only find sinusoidal dilatation and not fibrosis, then I feel comfortable like putting the label of the diagnosis. When you have someone with only splenomegaly, nothing else, and then you do the biopsy and you do not see the specific lesions, I think that here we still don't know, even if we, in my opinion, went a little bit wild on the definition, like including this as a diagnostic criteria, like non-specific clinical sign and non-specific histological sign. Probably we will need to revisit that in the future. But again, it was in an intent of gathering everything, putting everything in the same basket, and then being able to make the subgroups.
Yeah, thank you. Virginia is a very, very dear friend, and I think we can put our friends in tricky situations. It's permitted. So when we talk of, some of the non-specific features of PSVD, like dilatation of sinusoids. So this is a beautiful paper published in Hepatology, which demonstrated what are the mechanisms for dilatation of sinusoids. So anything that causes inflammation in the body, or any infection of an extrahepatic disease, can lead to sinusoidal dilatation because of interleukin-6 and the VEGF pathways. So it is a non-specific stimulation. Similarly, what we talked about the portal vein thrombosis in the beginning, chronic portal vein thrombosis and other conditions leading to a decreased portal venous flow. For example, if you have a congenital shunt, that can also cause non-zonal sinusoidal dilatation because of atrophy of hepatocytes and secondary dilatation. So it is really non-specific, and I'll give you one example. If a patient has, let's say, malaria, it causes inflammation, it will cause thrombocytopenia. You will have, if you do a biopsy, the SGOT-PT will be mildly increased. You do a biopsy, you will find sinusoidal dilatation. So will we call this malaria-associated PSVD? I don't know. If you look at the definition, this person fulfills the criteria of malaria-associated PSVD, because this is PSVD by definition. If you have a patient of dengue, you have inflammation, there is mild dilatation of, mild increase in SGOT, SGPT, you do biopsy, you will find sinusoidal dilatation. This person again will have thrombocytopenia, so will fulfill the definition of PSVD. But is it PSVD? I don't think so. So those are the problems. Similarly, for perisinusoidal fibrosis, Dominic has been instrumental in saying that it can coexist, PSVD can coexist with other diseases like hepatitis B, hepatitis C. But the problem is, again, all these disorders, the histological findings which are consistent with PSVD have been described in each of these disorders way back in 1980s in Ian Wanless in several of his papers. So to say that these are really two diseases coexisting, or it is a histological manifestation of hepatitis C, changes secondary to hepatitis C, we still don't know. I'm not saying that they are same or they are different, but we really don't know. So we need much more, I think, needling to differentiate between these two disorders in that aspect. Yes, Dominic.
The two slides that you've shown, it's exactly the reason why we didn't call them specific lesions. So if in the case of malaria, for example, we would need specific lesions to think of the diagnosis of PSVD, not just sinusoidal dilatation or things like that. That's the reason for putting the features non-specific or specific.
Yeah, but that's unfortunately in definition we say absence of cirrhosis and one non-specific pathology, one non-specific clinical. And these patients fulfill because they will also have splenomegaly.
So like if we can ask, there is a patient who has come with ascites and bleeding, and you do a liver biopsy transjugular and it doesn't show features of cirrhosis. So will you call it non-cirrhotic or a sampling error, which can be in 30% because you can't get a 15 millimeter or 20 millimeter tissue? So here is ascites there. The patient is bleeding, but biopsy does not confirm. What will you call it?
Yeah, I agree, sir. So that's why if you look at carefully in APASL 2024, we have said that in the absence of overt portal hypertension, this has to be only in the presence of the specific risk factors which are known to be associated with this disease. And then if you have consistent histological features like portal venopathy, NRH, or incomplete septal fibrosis, or non-specific features. So you have to have risk factors mandatorily, which are known to be associated with this to make a diagnosis. So that I think was more relevant. Coming back to Dr. Sareen, what will be the take-home messages for people who are practicing? So if you can summarize them.
Well, that's a difficult and tricky question. If you are living in Europe, maybe you can use PSVD or maybe some parts of the US. But I think if you are living in Asia, use what we clinically associate a patient and a liver pathology or liver pressure. So I am reminded of Harold Kahn, who said, if I have a variceal bleed, and if I am in the Europe, I'll go to the German, the guy who was doing all the endoscopy, I forgot his name, Amit's boss, uh,
Nips
Sohindra.
Ohindra.
I'll go to NIPS Sohindra. If I am in the US, I'll get a shunt surgery with Orlov. But if I am in this part, I'll go to Shiv Sarin and get this banding or sclerotherapy or whatever to be done. So the bottom line remains, which part of the world, we may be talking the same language, we may be having same, but the carry home message is the patient and a clear diagnosis. That is what I have grown up, but it can depend on the regions, and as Virginia and Northup said, we have more data to be done. For clinical practitioners, simple.
So coming back to Professor Kamath, the final question to you, because I mean, we have fantastic brains sitting over here right now in this panel, people who have done path-breaking work. But what we have done in the last decade has actually created confusion amongst people. So what would be your suggestion to the experts to settle this issue? Because I think it is high time that we move towards a common consensus which leads to everybody coming together and making the same diagnosis, whether it is in Asia, Europe, or US, or South America, or Africa for that matter, or Australia. But we need to have the same words, same languages, and same interpretations. So how do you think we can really achieve that?
So thank you. So for one thing, I think there is actually far less disagreement than is perceived. I think there's a lot of agreement here. To me, I don't care what you call it. It is ultimately what you're going to do about the patient. So calling it PSVD or idiopathic portal hypertension, I think is perfectly okay as long as each one knows what they're talking about and what is involved in here. Going forward, following up on what Dominic said, when we said stage 1, 2, 3, 4, rethinking it, we should have said type 1, 2, 3, 4, because some may just stay forever that way. Stage 1, 2, 3, 4 means everyone will go through that stage. So there are probably different types. I think the type 4 that we're talking about is the young patient with a big spleen and a variceal bleed, who's quite different from the type 1, which is associated with hematological disease. So I think we need a little better definition about these. Anytime we look at a disease, you have to look upon it from 3 different viewpoints. There's a patient and the family. Patient and the family probably don't care what we call it. They don't want to bleed. They don't want a hepatopulmonary syndrome if they're started on treatment. So we have to think about them. So for them, it doesn't matter. Idiopathic portal hypertension is a good term for the clinician when the patient presents with the clinician. I think PSVD is a good term for the investigator. My only suggestion would be for the investigator is not to lump all these together, because I think the presentations are quite different, and to pick groups of conditions here.
Thank you very much. I think that was my last question. We'll have, do we have time for 1 or 2 quick questions? But I'll sincerely request to be brief and to the point, because I think they have...
Very brief, Akash. How do type 1 or stage 1 NCPF present to you? asymptomatic, no splenomegaly, no portal hypertension, and you measure
Virginia,
the
you want to answer that?
and you measure the HVPG in them.
Virginia, you want to answer that? How will the one without portal hypertension present to you?
The pre-NCPF stage is actually a liver biopsy feature. The patient who has come to you and you find the OPV, obliterative portovenopathy or perisinusoidal fibrosis, but doesn't have.
Clinically, sir.
Clinically, it's pre-NCPF. It's not really there. It's an early stage which can be there. It's not diagnosed by clinical means, but yes, you can put it on biopsy that this patient.
But that is what I'm asking. How does the patient present to you? Why
sir,
should the patient come to you? Typically,
one question only, because there are others waiting. Yeah.
Yeah, one question is portosinusoidal vascular disease. I wish to know what will be the HVPG in this condition. Will there be not a disconcordance?
Sir, one question only, please, because the others waiting, sir.
Just
One
order.
question. Yes, sir.
Shukla,
What will be the HVPG, sir, in these patients?
and there will be a disconcordance between portovenous pressure and HVG pressure. Why not? And because of this term is wrong or correct, that this term appears dubious to me, portosinusoidal vascular disease. And secondly, Dr. Shukla, please, for our case discussion, 20 minutes, 18 minutes were given. For your case discussion, in place of 20 minutes, you have taken 1 hour, 20 minutes. I know you are organizer, but that distribution should be maintained.
Yeah.
Sir, just one question. For a clinician, what should be the starting point? Splenomegaly, portal hypertension, deranged LFTs. Where do I start?
I think those are like different clinical phenotypes. Sometimes you have a patient presenting with a splenomegaly, sometimes you have the patient presenting with a variceal bleeding, or sometimes what you have is a patient with a normal blood test, and then you do the biopsy and you see the signs. So it's really, it's a big spectrum.
That means it's all heterogeneous and it's been clubbed under PSVD.
Sorry?
So it's all heterogeneous presentation and it's been clubbed under PSVD definition.
Exactly. That's what we think, that we can put them
Professor
together.
Anand? Professor Anand.
I want HVPG answer to be clarified, please, by any panel. Yeah, Dr. Sareen can clarify HVPG.
No, you know my point of view because you were part of the guidelines in the beginning, but let's see what HVPG is in PSVD.
I mean, we all know that this is a pre-sinusoidal or has an important pre-sinusoidal component that we will not capture with HVPG, right? So I still prefer like doing HVPG. Why? Because I can have like the anatomy of the veins. I can see that it's not high, even if it's not always mandatory, and I can have the biopsy. But in the cases where we have doubt or where it's important to know if the patient has or not portal hypertension, what we do at my institution is direct portal vein, US guided percutaneous portal vein measurement.
Normally, in the PSVD, you have normal or near normal portal pressure done through the
HVPG, yes.
Yeah, that's precisely, but the paper in gut and others, about 30% of the patients have more than 10 HVPG. So the question is, if the HVPG is high, will you consider it as cirrhosis or you will call it as PSVD?
I will never rely only on a pressure measurement. I will do elastography of the spleen, elastography of and then the histology.
No, patient has a site, varices and variceal bleed, and then also you will derive for portal hypertension on fibroscan only. Patient has variceal bleed. And what do you expect in the world sinusoidal? Will the HVPG be normal or it will be raised?
Yeah. Yes, Professor Anand.
Can I ask? For a person who's been using the term NCPF for last about 45 years, I'd like to know what was the problem with this word? It explains everything. Do we have some comments on this?
I can't speak to the nomenclature, but I would discourage us as people who are setting policies and making diagnosis, I would discourage the use of non or idiopathic in a medical term because they are heterogeneously used throughout medicine and they're confusing, similar with cryptogenic. That term is confusing, and we're just confusing ourselves with it. We ran into problems with non-alcoholic steatohepatitis because of the word non in there. Let's not make a diagnosis name based on something not being there.
I think, thank you so much. We'll have to conclude this session. Thank you so much, panelists. And before we break for the tea and before the tea starts, we have our guest of honor for the day. I'd like to request Dr. Tarang Gyanchandani, the CEO of Sir H.N. Reliance Foundation Hospital, the dynamic leader. She has been awarded several times for her leadership in healthcare. She would love to address the gathering. So over to you, Dr. Tarang Gyanchandani. And thank you, sir, so much. Thank you, each one of you. It was really exhilarating session. Thank you.
A very, very good morning to our esteemed national and international colleagues, distinguished guests, and pioneers in the field of liver care. I assure you that I will make sure that this few words that I'm saying do not go beyond 10 to 12 minutes so that you are not delayed for your tea. And that's the time which I have been given. So we'll make sure that I stick to the time. It's indeed my privilege to be here on behalf of Sir H.N. Reliance Foundation Hospital to be amongst all of you at the Build 3.0, a platform where ideas take shape, where boundaries are challenged, and where the future of liver disease management and transplant medicine is being redefined. I can see so many national and international luminaries in the field of hepatology here today. Liver disease is no longer a silent epidemic. It is one of the most pressing global healthcare challenges of our times. Today, it accounts for 1 in every 25 deaths worldwide, making it the 10th leading cause of mortality, especially for India. The burden is immense, and yet within this challenge lies an opportunity to innovate, collaborate, and transform lives. At Sir H.N. Reliance Foundation Hospital, our commitment has always been to lead this transformation, ensuring that every patient, regardless of geography or financial constraints, has access to the world-class liver care. Over the years, RFH has emerged as a center of excellence for liver disease and transplantation, driven by the unwavering pursuit of clinical brilliance, technological advancement, and the patient-centered care that we provide to our patients. Under the leadership of Dr. Akash Shukla and Dr. Ravi Monka, we have a multidisciplinary approach to not only the pioneering breakthroughs in hepatology, but also we set new benchmarks for liver transplant every day across India. Today, I am proud to share that in a very short span, we have successfully performed over 150 liver transplants with survival rates that match and in some cases even surpass the global standards. But what truly sets us apart is not just a number. It is the complexity and innovations behind each and every procedure. At RFH, we have established a collaborative network of hospitals across Western India, ensuring that our expert transplant care is accessible beyond the metropolitan cities. Our pioneering cutting-edge procedures include robotic hepatectomies, ABO-incompatible transplants, dual-lobe liver transplants, simultaneous liver-kidney transplants, and we have recently done a simultaneous heart and liver transplant as well. It's completely overwhelming when we see such complex transplants happening and the patients walking out of the hospital happily. We are also doing significant work in postpartum liver failure management, which is first of its kind case in India, where we saved a young mother's life through an urgent liver transplant. These are not just medical milestones, these are testaments to our commitment for pushing the boundaries of what is possible. Medicines can cure diseases, but only innovations can cure the limitations of medicine itself. Our journey is far from over. In the next decade, we envision future where the liver disease is no longer the end of the road, but something which is a part of the road and we can move beyond. I don't think it'll take us even the next decade if we all put in our collaborative efforts together to reach the next level in the field of liver diseases and the transplants. Some of the things that we are especially focused on, and I've always given that challenge to the team, is that we don't have a decade with us. We have merely few years with us to accomplish all this. And we would want to accomplish this 5 years or earlier. And some of these activities include is that we want to expand our transplants outreach to the tier 2s and tier 3 cities, ensuring more lives are saved across the country. We would also step strongly into the field of AI and predictive analysis in hepatology, developing machine learning models for early disease detection and personalized treatment protocol. I personally feel that it is not only the treating diseases with the high-end care in the quaternary care hospital, but it is also very, very important in the next few years that we should accomplish how to do early detection and prevent these diseases from getting into a stage where liver transplant becomes imminent. Another important area that we are all looking at working is regenerative hepatology, whereby we would like to explore stem cell therapies and bioengineered liver assist devices to delay or even replace the need of transplant. I know we have some breakthroughs coming up from the various parts of the world, but I think it's time for India to not only embrace it, but also excel in it. And last but not the least, most importantly, an integrated multidisciplinary liver care approach whereby we create a one-stop liver health ecosystem where the hepatologists, the oncologists, the transplant surgeons work together in a perfect synergy. To lead this bold vision forward, we have assembled one of the most exceptional teams in liver transplant. It is my privilege to welcome Dr. Gaurav Gupta and his team at Sir H.N. Reliance Foundation Hospital to augment our liver program further. The team together under the guidance and leadership of Dr. Ravi Mohanka will represent the next era of hepatobiliary excellence where expertise meets innovation and innovation would meet impact. The true measure of a physician is not in the numbers of procedures performed, but in the lives changed, the fears eased, and the futures rebuilt. I now would like to leave you all with one thought. The challenge of liver diseases cannot be solved by one hospital, one doctor, one technology. It needs collaboration, it needs a foresight and a relentless commitment by everyone to push the boundaries of what is possible. Together, we can build a future where no patient is denied of transplant or liver care due to cost or distance. Every liver disease is diagnosed before it reaches a critical stage. In the next decade of liver care, we have to focus on innovation, compassion, and accessibility. I know most of the time the doctors are more focused in finding the best solution for the patients and doing the best for their patients, but the time has come where we all have to work together as to how to increase the accessibility of this. And this would mean use of new innovative tools. This would mean definitely harnessing digital health and AI to spread the awareness and to focus on early detection. The problem is that the focus today of the whole, all of our mindsets globally is on treatments. Even if we are multiplied by an infinite number, we will never be able to meet the demand of care. So the idea is that we have to reduce the demand, reduce the burden of the disease in such a terminal stage that it leads to such high mortality rates. I'm sure that is what something like all of you here, Dr. Akash, Dr. Serene, would envision to finally happen in the field of liver care. Before I step aside, I want to take a moment to thank each one of you here. I know today is the third day. You had great sessions over the last 2 days. So really a big thank you for all of you to taking out your time and being here. Not just for being today, but also working collaboratively to find out the advancing science and new practices to hepatology and liver transplantation. Your efforts will save lives, restore hope, and redefine what is possible in healthcare. My heartfelt congratulations to all the award winners yesterday. I'm sorry because of something urgent, I couldn't make it for the program. But I had promised Dr. Akash that I would really like to come because this is a very important subject and a very important focus area for not only us as a hospital, but for us as a group. At the heart of these advancements in our hospital in liver disease is Dr. Akash Shukla, who is our visionary in the field of hepatology and whose dedication to pioneering research, clinical excellence, and patient-centric innovation has transformed liver care significantly in not only in our hospital, but I really believe in the entire country. His leadership has played a vital role in strengthening our transplant ecosystem and ensuring that more patients receive the world-class care when they need it the most. And it's so overwhelming to see how he fights for each of his patients, how he reaches out to each one of the global leaders whenever we ask him, okay, what best we can do for this patient. Whether the patient is affording or not has never been an issue or a concern in our hospital. We are very thankful to our chairman, Mr. Mukesh Ambani, and our chairperson, Mrs. Neeta Ambani, and our director, our whole and soul, Mr. Anand Ambani, who has never ever questioned us anything on technology or when it comes to supporting our patients. But it is the effort that everyone in our transplant team as well as in our Department of Hepatology under Dr. Akash Shukla puts in to ensure that we get them everything together and we work towards together to save lives and restore the hopes. I'm sure that with your all efforts, Dr. Akash, you are already a respected person in the field of hepatology in the country, and I envision you as one of the brightest leaders globally in times to come. With this, once again, thank you everyone, and please continue to push the boundaries, learn from each other, and also give it a thought, how do we make it more accessible and how do we all work collaboratively to ensure that we work towards early screening of liver diseases? How do we spread the awareness that people should come forwards? Because I think we all have learned medicine before, much after, sorry, we learn prevention is better than cure. So I think it's time for all of the global leaders to put in their efforts into also looking at how to prevent the disease and how to also spread the awareness so that the detection happens earlier. Once again, I'm really, really thankful to all of you here today, and especially the august audience here. I'm sure I'll meet some of you at the hospital in the next couple of days. And once again, a big thank you on behalf of Sir H. and Reliance Foundation Hospital for making these 3 days wonderful and enriching for everyone. Thank you very much. Namaste.